So, morning. My name's Tim Biggs. I'm a Rhinology Research Fellow working in the Southampton Upper Airway Research Group under Professor Salib. And I'm going to be talking about some of our work, characterisation of interactions between Staph aureus and mast cells. So as we know, chronic rhinosinusitis is a chronic condition affecting up to 15% of the population. Around 20% of these patients develop nasal polyps. And bacteria, most notably Staph aureus, have been found on the surface of patients' sinonasal mucosa. We've also found recently, through Steve Hayes' work, that the bacteria reside intracellularly in nasal polyps, and the cell type that this has been found in is mast cells, which was a novel and unique finding, given the role of mast cells normally in allergic disease, and not necessarily bacterial work. And my work is focused on the interactions of this Staph aureus with mast cells to see whether they're involved in the disease process. So in terms of methods, I've used two different cell lines, a HMC1 mast cell line, which is an immature mast cell line, similar to circulating mast cells, and a LAD2 mast cell, which is a much mature mast cell line, which is more representative of tissue-resident mast cells. Looked at confocal laser scanning microscopy, colony-forming unit enumerations, where we look at the amount of bacteria that we can grow from the cells, and also the inflammation through gene expression, real-time PCR, and protein production through Luminex. So going through the results, we can see that Staph aureus survives within mast cells. So looking at both the HMC1 and the LAD2 mast cell line, we've got our control patients, and as you add in the bacteria, which is our smaller green and red, over the period of infection, they seem to take up more bacteria. Interestingly, I chose this picture to add in at the 6-hour point because this cell is dividing, so the cell is still going on its normal processes, despite the fact that there's a large amount of bacteria residing within it. When looking at enumeration of bacteria, so we've done some experiments looking at the intracellular bacteria. So this is colony-forming units where we take the cells, we wash away all of the extracellular bacteria, and then we plate the intracellular bacteria once we've lysed the cells. As we go up the infection time points, there's more and more bacteria, which is viable, live bacteria, capable of being released. What's also interesting is when we eradicate all of the extracellular bacteria at 6 hours and continue the infection for 24 hours, there's still an increase in the number of viable intracellular bacteria. When we look at the extracellular bacteria, this is at the 6-hour time point, so 10 to the 7 amount of bacteria within our cultures. When we eradicate all of this bacteria and continue the cells for 24 hours, there's a resurrection of all of the extracellular bacteria, which indicates that these cells are splitting open, releasing the bacteria, and really the intracellular colonies are the tip of the iceberg, and they're propagating ongoing infection. Looking at the inflammatory response of this, I've looked at a number of cytokines. This is Luminex data looking at protein production. So TNF-alpha is a general cytokine, this is a Th1, and this is an antibacterial cytokine. When we look at control compared to live groups in green, and we've got live bacteria and live bacteria plus SEB. SEB is a potent toxin produced by Staph aureus, which has been found in some situations to progress inflammation. There's quite a strong pro-inflammatory response of these bacteria towards the mast cells. Interestingly, the dead bacteria doesn't really seem to have much of an effect. So although it's probably recognised by the cell, it doesn't produce this ongoing inflammation. And SEB alone doesn't have an effect that we've found in terms of inflammation on mast cells, but it's likely to interact with other cell types such as epithelial cells. When looking at when this occurs, when we do confocal, we can see that there's binding of external bacteria around 2 hours and intracellular bacteria at 4 hours, highlighted here by the white arrow. We can see that when we look at the time course of the inflammatory response compared to the control situation, this potent inflammatory responses around the 4 to 6 hour time point, which is where we see internalisation. So there's no doubt that not only are the bacteria hiding within the mast cells, but that process produces ongoing inflammation. What I was interested to look at is what effect does the internalisation have on the Staph aureus and whether that promotes a phenotypic change in that Staph aureus. So what we did an experiment where we grew the bacteria, we added it to the mast cells, we left it for 4 hours so that it intracellularized. We got rid of all of the extracellular bacteria, washed the cells multiple times, used an antibiotic that doesn't cross the cell membrane, so it just gets rid of all of the extracellular bacteria. Make sure we streak this on a plate to make sure there's no extracellular bacteria. Lyse, receive or obtain the intracellular bacteria, and then repeat this process 5 times sequentially to see whether there's a phenotypic change in that bacteria. Interesting, when we look at the CFU, so this is looking at the number of bacteria, when we look at our original stock isolate compared to the once internalised, 3 times internalised and 5 times internalised, actually there's no difference, no significant difference in the amount of uptake of this bacteria. However, looking at the immune response, there's quite a significant difference. So if we've got a number of pro-inflammatory cytokines. When we add in Staph aureus, our stock that we receive from a patient with CRS, there is a pro-inflammatory response. Once we internalise this once, it's even more pro-inflammatory. But looking at the 5 times internalisation, there's a significant drop-off after this point, indicating that when the bacteria is initially targeting the mast cells, there's a potent pro-inflammatory response. As it becomes a chronic process and there's release, uptake, there's less of an immune response, potentially meaning that the bacteria are going to survive within the subepithelium for a longer period of time. We've also proposed a model looking at some of Steve's work that's led on to my work, trying to understand how this could all fit together and produce ongoing inflammation and potentially the formation of nasal polyps. We've done work showing that bacteria is on the surface of epithelial cells. I've used an epithelial model to show that the bacteria is taken up into the epithelial model, enhanced through the action of SEB, which is this toxin. It produces a strong pro-inflammatory response, which brings in mast cells to the area. These mast cells take up bacteria, produce degranulation and an immune response, which contributes to an ongoing chronic situation, and also is involved in reseeding of bacteria, which propagates ongoing disease. We've found that when the Staph aureus is taken up and released multiple times, there's a reduction in the pro-inflammatory response, potentially allowing the bacteria to survive in that environment for a longer period of time. And we've done some work looking at the allergic response of this and IgE sensitization, which we're going to give a talk a bit later this morning. So in conclusion, Staph aureus internalises and survives. It produces a strong pro-inflammatory response, and Staph aureus is able to modulate this immune response through its uptake and release. Our proposed model is a small piece of what is clearly a large jigsaw puzzle of CRS, but it may help improve our understanding and help with the advent of novel therapies. Just like to thank my supervisors, but most notably Professor Salib and also Stephen Hayes for doing some of the earlier work which led on to my work, and also my funding bodies. Thank you very much.